Welcome to This Week in Obstetrics and Gynecology. This week we're covering 10 notable papers spanning the management of obstetric hemorrhage, advances in high-risk obstetrics, and new insights in gynecology and reproductive medicine. Let's dive in. We begin with a major focus on postpartum hemorrhage, highlighted by a comprehensive series in the Lancet. PPH remains a global catastrophe, affecting an estimated 27 million women annually and causing a maternal death every 12 minutes. The series underscores that PPH is not just a treatment issue, but one that requires a multi-pronged approach, starting with prevention. A paper by Gallos and colleagues reviews the evidence for PPH prevention, emphasizing strategies beyond just uterotonics. These include addressing the unmet need for contraception, managing pre-pregnancy anemia, and tackling the rising rates of non-medically indicated cesarean births, which substantially increase PPH risk. A Cochrane Network meta-analysis of over 120,000 women found that combination uterotonics like oxytocin plus misoprostol are most effective but carry more side effects. Therefore, for routine prophylaxis, single agents like oxytocin or carbetocin are recommended for their favorable safety profile. For women at high risk, however, combination prophylaxis with oxytocin plus misoprostol can be considered. When prevention fails, prompt diagnosis and treatment are a race against time. Another paper in the series emphasizes that subjective visual estimation of blood loss is dangerously inaccurate, missing over half of PPH diagnoses at vaginal birth. The WHO and other bodies now recommend objective quantification of blood loss, for example with a calibrated drape, coupled with a first response treatment bundle. The authors identify 6 critical delays to avoid. Delays in diagnosis, in first response treatment, in escalation, in using temporizing measures, in identifying specific causes, and in providing blood products. Rounding out this theme, a perspective in PLOS medicine discusses placenta accreta spectrum, a major cause of severe refractory hemorrhage. The authors argue that our long-held understanding of its pathophysiology is being challenged by new evidence, and that a critical reassessment of its definition, diagnosis, and management is overdue. Next, we turn to advances in high-risk obstetrics. From Ultrasound in Obstetrics and Gynecology, a systematic review and meta-analysis explored whether guiding antihypertensive therapy by maternal hemodynamics improves outcomes in hypertensive disorders of pregnancy. The analysis, which included 6 studies, found that compared to standard care based on blood pressure thresholds, hemodynamics-guided therapy was associated with a 53% reduction in the odds of preeclampsia or eclampsia, a 61% reduction in severe hypertension, and a 46% reduction in fetal growth restriction. While these findings are promising, the authors caution that the overall certainty of evidence was low to very low, largely due to non-randomized study designs. Therefore, these results should be considered hypothesis-generating and require confirmation in large randomized controlled trials. Also in Ultrasound in Obstetrics and Gynecology, a report from the International Fetal Cardiac Intervention Registry provides new data on in utero intervention for hydropic fetuses with congenital heart disease. In this cohort of 91 hydropic fetuses, 73 underwent a fetal cardiac intervention. The results show a potential survival benefit, with about 1/3 of treated fetuses surviving to hospital discharge. This contrasts sharply with the expectant management group, where only 1 of 18 survived. However, the intervention carries significant risk, with a procedure-related fetal loss rate of about 1 in 5. The majority of survivors had biventricular circulation at last follow-up. Finally, a population-based study in Obstetrics and Gynecology examines 25 years of United States data on black-white differences in neonatal survival among periviable births. The study found that a previously observed survival advantage for black periviable neonates has eroded over time. Between 1995 and 2019, the risk of neonatal death declined for both groups, but the improvement was faster for white neonates, whose risk fell by 18%, compared to only 13% for black neonates. Because black births are disproportionately represented among periviable deliveries, this slower rate of improvement means that a disproportionate burden of periviable deaths continues to be borne by black neonates, highlighting persistent inequities in care and outcomes. Our final theme covers new insights in gynecology and reproductive medicine. In the American Journal of Obstetrics and Gynecology, researchers used a novel approach called Q methodology to better understand patient perspectives on treatment for female chronic pelvic pain. They identified 5 distinct patient preference profiles, with names like the self-empowered realist and the careful scientist. The goal is to use these profiles to develop tools that can help clinicians align treatment counseling with a patient-specific viewpoint, potentially improving engagement and compliance with therapy. In basic science, a study in Cell provides a deeper understanding of why human pre-implantation development is so inefficient, with about half of fertilized eggs arresting. By imaging live human embryos for up to 5 days, researchers identified 2 distinct causes for this low efficiency. Early embryonic arrest was most often caused by errors during the second mitotic division, leading to chromosome missegregation and micronuclei formation. In contrast, late embryonic arrest was largely independent of these errors, and instead involved the activation of an endoplasmic reticulum stress response that impaired blastocyst formation. The researchers also noted that a PLK4 inhibitor could suppress some of the errors, leading to early arrest. And finally, from Obstetrics and Gynecology, a systematic review and meta-analysis of 11 randomized controlled trials involving nearly 10,000 women compared endometrial preparation protocols for frozen embryo transfer. The results showed that a natural cycle protocol was associated with significantly higher live birth rates compared to an artificial programmed cycle, 41.5% versus 39.2%. Digging deeper, the benefit was driven by modified natural cycles that use an HCG trigger to time the transfer. True natural cycles without a trigger showed no significant difference. Furthermore, natural cycles were associated with significantly lower rates of miscarriage. The number needed to treat to achieve 1 additional live birth with a natural cycle was 23. If you only have time for one paper this week, make it the systematic review and meta-analysis on endometrial preparation for frozen embryo transfer in obstetrics and gynecology. It provides moderate quality evidence from randomized trials suggesting that a modified natural cycle protocol is associated with higher live birth rates and lower miscarriage rates compared to artificial cycles for a very common procedure. Here are the key takeaways from this week in obstetrics and gynecology. First, for postpartum hemorrhage, objective blood loss measurement is critical for timely diagnosis. For prevention in high-risk patients, consider combination eutotonic prophylaxis with oxytocin and misoprostol, while single-agent oxytocin or carbetocin remain standard for routine use. Second, in frozen embryo transfer, a modified natural cycle with an HCG trigger appears superior to artificial cycle preparation, associated with higher live birth rates and lower miscarriage rates. Third, hemodynamics-guided therapy for hypertensive disorders of pregnancy shows promise for improving maternal and perinatal outcomes. But high-quality randomized trials are urgently needed to confirm these findings. And fourth, the historical survival advantage for Black periviable neonates has diminished over the past 25 years in the United States, highlighting persistent disparities and slower improvements in care for this vulnerable group. That's your roundup for this week in obstetrics and gynecology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.